As you can see, I choose controversial topics to work on. When I looked at the program here, I thought, wow, my presentation is the very last one. That's a good place for ethics. It always comes at the end. And it's often an afterthought. But being here the last several days, I actually realized that it has hardly been a session that some ethical issue didn't come up. So in fact, that made my job today a lot easier, because what I have to do is to give you a summary of what you all have been discussing in a lot of detail over the last several days. My job was to look at key arguments and issues that come up in relation to personalized genomics, and I was asked if I could specifically look at issues that relate to direct-to-consumer genetic testing. So I'm going to do that. I'm going to summarize the key arguments, and I try to look at whether those kind of arguments and the way they have been shaped to date, whether they are telling us anything about which direction we should be going to in relation to policy making. I think what's important to say, to put that debate a little bit in context, is that the ethics debate, at least on this issue, has been influenced by the sort of uncertainty that we have been hearing about the clinical validity and utility of the information that these tests generate. And it's very important to keep that in mind, because I think if we had certainty, the ethical debate would have been different. In 2009, Professor Green, whom you heard yesterday, wrote a paper entitled Direct-to-Consumer Genetic Testings, Avoiding a Culture War. And it was quite interesting to look to have that on a title. He was referring, he and James Evans, they were referring about exactly to that tension in the scientific community about what exactly the direct-to-consumer genetic tests are telling us, whether we should be using them. And in fact, it was a call to the community to kind of, get rid of the animosity that seemed to be building up and work together in seeing how we're going to be going forward. Well, I asked Professor Green the other day where he thinks that since 2009, if we had the war, or if things are getting better, and he seemed to think that we're on the right track. Another thing which is helpful to put the debate in context is how professional associations have been dealing with that. The European Society for Human Genetics, just after their last meeting, their last annual meeting, put out a press release, I think in the spring, in fact communicating to the public that DDC genetic testing is neither accurate nor beneficial to consumers. That was a pretty bold statement. They have more nuanced statements, the European Society, the American Society, where they actually call for caution. Those of you who are following what's happening in the US, you probably have heard the Food and Drug Administration's review last year of direct-to-consumer genetic companies and discrepancies they found, issues with quality, some ethical transgressions, and that created a big hype in the media. So keep in mind that's the context. Now, the arguments, there have been lots of arguments in the ethics debate, in the ethics literature, and what I will do, I will take these arguments around some basic principles and values that we use in the discourse of ethics. I think it's a helpful way to structure them. And these are principles and values that you're all very familiar with: respect for autonomy, beneficence and non-maleficence, issues of distributive justice and equity, also the state's responsibility to protect or not to protect, and I will refer very briefly to the right to know or not to know, because you've heard already a lot about it. So respect for autonomy, a pillar in biomedical ethics. That's a very important principle. It's all about self-determination. We are agents who are able to make decisions, take action, and serve our best interests. So the argument goes that if you have access to direct-to-consumer genetic tests and the information that comes out of it, that you've got an opportunity to act, or not to act, that's your choice, but at least you have, it creates an opportunity for you to improve your life. This is how the argument goes. Follows that, if you don't have access to that, you're deprived of that opportunity to act. So a free agent is exercising self-determination and autonomy, can go and get this information. Now, an important actually, putting the respect for autonomy issue in our current context, I think it helps us understand some of the nuances. The Nuffield Council of Bioethics produced last year a very interesting report exactly on the ethics of personalized healthcare. And what they did was to place the debate in the context of what they called consumerism and responsabilization. With consumerism, they actually refer to this whole trend of all of us feeling consumers, especially also in the healthcare, and having a lot of purchasable health goods. So that's one very important social change over time. The second one is responsabilization, this increased tendency to be more responsible about health. And this is something that people start liking, they start doing, but also we should know that this is something that healthcare programs, the state itself, is promoting. They tell us, take your health in your hands, don't smoke, don't eat too much, go and exercise, take responsibility over your health. And I'll come back to why this tendency to being more responsible in health is important. It fits quite well. If you're a consumer and you're responsible, you're ending up being a more empowered patient or citizen. And in that context, the respect of autonomy becomes even more important. Now, there's a catch. The respect of autonomy, what we said before is that, okay, you go out there, get this information. One of the issues we've put a lot of has been heavily discussed is that action or inaction, while you're exercising your self-determination, is related to the quality of information you'll be receiving. And this has been one of the points where the discussion got quite hot. What we are thinking in relation to information that we get in general in healthcare or in health is that information has to be accurate, has to be meaningful, has to be balanced, has to be evidence-based. We should be able to make sense of it, in other words. That's a logo of Department of Health in the United Kingdom organization, which actually gives certificates to websites that provide health information, and it looks at whether the information that is out there fulfill those criteria. So we're all thinking, not only in genetics, but in general, that information that we give to people, the quality is critically important for the action or not they're going to be taking. Okay, so, whoops. Now, how do we, traditionally in healthcare and in clinical research and clinical practice, we safeguard autonomy? Surely we're free, we have to be, nobody should violate this principle. How do we do that in the clinical context? And the safeguards we put is informed consent. What we do, people need to understand what they're signing up for. We've been talking about valid consent. Is the person who says yes to, agrees to that, understand that? Is it capable of making the decision? So, for example, we're not talking about valid consent when somebody's in coma, because we assume that it doesn't have the capacity to comprehend the information process and make a decision to his or her best interest. And from that derives our other obligation to protect those who we're considering vulnerable. Vulnerable because exactly they don't have the capacity to make those decisions. Now, another way we try to safeguard autonomy is with gatekeepers. In this case, would be counseling. We're telling people, well, because it might be difficult to understand this kind of information, we'll get somebody who is explaining to you why it puts this information in context. In the case of genetic testing, puts it in the context of your other risks, of your family history, environment, and makes you understand better what this is all about. Now, that's a point of contest in the case of direct-to-consumer genetic testing. Some people say, well, you know, that's critically important. If people don't understand the context of this information, they'll be making the wrong decisions. And others say, well, why not? I mean, they're not necessarily going to be making the wrong decision because you've got lots of information given to them online, for example, and you don't need that tutorial with the counseling. This has not been resolved, but the tendency is a lot of people, the majority of people tend to think that we need that safeguard with counseling. Now, other issues that relate to respect of autonomy and have been raised in the context of genetic testing directly to consumers is whether the way the system is done, you can do it online, you've heard how you can send your sputum and have it tested, might leave a hole of people testing others people, sending samples of other people's which is clearly not legal, but it can be done because of the loophole. If you're going to the doctor, he's taking your blood. The next set, which is even more, I think, controversial, is what about genetic testing, especially direct-to-consumer, of minors, children. There's a lot of discussion going on about that. Children, it's one of the populations we tend to protect, and rightly so. They have diminished autonomy because they don't have the capacity to understand the magnitude of the information they receive. We also know, however, that minors have evolving capacities. You will agree with me that a 3-year-old and a 16-year-old have different capacities, and they make different decisions. So we have to be building that into that. They also have, however, especially in the case of lack of counseling, maybe the issue of them making the analysis of the risk-benefit being a bit more complex. One of the commentators on that has written actually a hypothetical scenario where a 15-year-old online buys a test, gets back results saying that he's positive for Huntington's disease, doesn't know what to do with it, gets depressed, gets really sad, goes and commits suicide. Is that okay? Well, nobody would say that that's okay. Is that an extreme hypothesis? Probably yes. But yet, what I thought was interesting in the commentary is if you push us to think what can happen in the extremes, maybe we are putting things slightly more in perspective. Okay, back. Now, the next set of issues, which I find particularly interesting, are actually structured around the principle of beneficence and non-maleficence. Beneficence tells us do good, no harm. And in other ways, it tells us maximize benefits and minimize risks. And we want to do that with the individual when we're in the clinical setting. We want to do that with society in cases of, in the world of public health. And there's constantly an interaction between the two, as I think you'll agree with me. Now, very often we talk about, in order to assess whether we can maximize benefits and minimize risks, we're talking about the risk-benefit ratio, either for the individual, either for the society. Risk-benefit ratio is a very interesting concept. Those of you who have sat in ethics review committees, you know that when you're assessing a protocol, that's basically what you're focusing on. Do risks here outweigh the benefits and therefore drop it, or do benefits outweigh the risk and therefore keep it? In order to assess that, to come up with that ratio and find out is it favorable or not, we need to look at what are the benefits and what are the harms. So the benefits that you've heard of and they've been put forward are that, if you have access to this information, you can have an impact. Your life change, you can have life changes, you can take personal control over your health, you can alert your family members if something is meaningful and useful. Increased genetic literacy, people can get more conversant with their genomes, the genetic information, that can have also important implications for the future. With blue is more the collective good. People argue that you can actually reduce healthcare costs if people, through this process, have healthier lifestyles or take the right prevention measures so they are, at the end, costing less to the healthcare system. Or, as we heard yesterday, if research goes on in this direction, we will get better drugs, more useful drugs, drugs for the right people. So we would actually have a reduction of health costs that way. And we will have another collective good, which is the contribution to research. People through these systems have the opportunity to contribute to research. And you'd agree with me that medical progress without research is hard to imagine. Coming to harms. Well, the argument is people have to pay for it. It's not free. It will create issues. The main key and main issue here is people will probably get false reassurance because the information is not contextualized or because misinterpreted or because it's ambiguous. People will think that they are not at risk while they are, or they might not be, or who knows, or they might get really anxious and depressed and very sad. So there you'd have a real harm for not perhaps the right reasons. People are very worried about the potential for genetic discrimination. And I'd like to say here that it's not only the potential of genetic discrimination as it's for employment or insurance, because we've been hearing there's laws in place to protect that. But people are also worried about genetic discrimination and stigmatization, which might affect your social relationships. I mean, the law might say that you cannot fire me because I'm going to develop that disease, but it might affect the way people see me. So people are concerned about that in a broader sense. There are a lot of concerns about privacy and confidentiality, and I'll come back to this later. Also, there's a worry that, in fact, because people might get overly worried about things, they might go back to the healthcare system and start ruining it by requesting more screening, more diagnosis, perhaps for the wrong reasons. And finally, people have put out, again, the argument of genetic determinism. If we keep telling people that they should be looking at their genome, at their genetic information and pay too much attention to it, are we basically undermining the value and the importance of all the other reasons? Environmental. And that would be a major blow to public health programs. My question here is, and these are sort of a quick view of what we would consider benefits and risk. My question is, are we able to answer actually that question? Can we get a figure here? Are these risks and benefits that we've described and we've been hearing measurable in some way? Because it seems to me that we're putting so much attention to that. We need a ratio, but I'm kind of worried that it's not something that we have produced some robust data on. Well, why is this relevant? Because, of course, it's a moral issue whether we do harm or not. It's a moral issue to respect the principle of beneficence. But I'm worried that it might have policy implications. And if we're saying that we're worried about the risk-benefit ratio in this case, which is an ethical argument, are we having a clear answer and based on data, or are we having an intuitive projection to something? Now, you heard yesterday from Professor Green that there is data coming, that we've got data. Well, it's not conclusive data. We don't have all the data we wanted to know. It's sometimes hard to measure also this kind of risk or benefit. But the data that is coming out slowly but steadily about potential harm or impact are actually telling us that we shouldn't be that worried. They tell us that in terms of potential harm and that being incredible anxiety or people going crazy and jumping off the bridges because they hear they might have 23% more risk of developing a certain disease, it's not actually happening. Surely we don't have conclusive evidence, but this is what we're seeing. On the other hand, what we're seeing, which is very interesting, we're seeing that this information doesn't have an incredible impact on life-changing. It doesn't have an incredible, people don't start riding their bikes, doing exercise and quitting smoking. Some will do, others don't. And we don't know what the effect is over time. Once you got this information and you got very active right away, what happens a year later or 2 years later? So we're kind of feeling, and again, that's not conclusive evidence. We need to collect more data. But it seems to me that it's not really dramatic either way. So we really need to be a lot more cautious about how you were using that, perhaps trying to create more robust evidence through systematic reviews or some meta-analysis of the data that's come back. And we definitely need to collect more evidence from different cultural environments. I have to say that most of the evidence is coming out, it's from the United States, probably because the market there is bigger than in other countries. But I think when we're talking about risk assessment and behavior and health behavior, there's a huge cultural component which might influence that. So I'd be very happy to see more results coming out of different contexts. And in fact, I couldn't resist the temptation of telling you that we're trying to do a little bit of that in Switzerland. The first slide, so what we did actually, we asked some people who did tests with 23andMe to give us a feeling about how things went. This is the survey we closed last week, so we didn't have time to analyze. That's very raw. It doesn't tell you much. We'll put the things together and do the analysis, and we'll communicate that later on. The first slide tells you basically that Ernst Hafen is a pioneer because he introduced that topic in a group of people who study biology or related sciences. That was ETH and University of Zurich. With some seminars and talks. We asked those, and those are people who did the test. So we asked them if they knew about it before Ernst's presentations, and as you can see, most of them, and these are people in that field, didn't know about it. I think if we ask the broader community, we might even have more startling results. Now, we asked those people who did the test about their overall experience, which seemed to be positive. We asked them whether they would recommend that to a family member or a friend, and the majority says yes. We asked them if they're going to show the data to their doctor. And we can't really infer a conclusion. It's kind of mixed. Most think no, some yes, and the undecided will probably determine what direction we're going. When we asked if they're going to talk about it with their families, they said yes. The overwhelming majority would say yes, and that matches actually what we've been seeing in the literature anyway. Another question we had was whether they think that they would participate in surveys that 23andMe is doing. And again, the majority got a positive response. Now, we have asked a lot of these are open questions where we're trying to get more nuanced ideas about what people are thinking through the open questions. But as I said, we were not able to analyze that for this meeting. Now, in relation, so a next topic of issue, and has something to do with research actually, it's that of our privacy concerns. You've heard here in the discussion, privacy came up a few times. People are worried about privacy. Privacy is important. There are legal protections about it. But we're kind of worried about our genetic data, and we're worried about how our genetic data, if they're in the hands of a company, how these companies are protecting them. Now, companies are telling you that they're doing their best to protect, but I think the message that goes around is also that in today's world, and the way we keep our data, it might be false to believe that we're absolutely and totally safe. Those who are following what's happening, US news, you might have heard that last week, the Stanford hospital medical records that are very, very tightly and safely kept records, they have been accidentally online for a year on a web page that pays for homework, like an irrelevant thing. For over a year, details, names, credit cards, identification codes of diseases were out there. So it's a complex and challenging world we live in. Now, is the legal protection adequate for privacy specifically on the genetic data? Well, we've been hearing there's a lot of legal protection about that, but whether it actually ensures and it suffices, that's an open question. The other thing that I've been hearing a lot, and I think it's interesting to think about, and I don't have an answer to that, is whether our notion of privacy is changing in the world we're living in. I mean, you know, of those of you who don't have a Facebook page, but you know people who have a Facebook account, people share a lot of their information. Surely they share them with their friends. But they're out there. A lot of people just have public profiles. A lot of people go out and put up a lot of information about themselves. Sometimes I look at them and I'm thinking myself, wow, you know, people are out there. Are they out there because they don't understand the risks? Are they out there because they couldn't care less? I don't know. But it's a question, I think, to start thinking about whether the way we perceive and we think of privacy in today's world, where it's exactly the same as we have been thinking about it over time. In particular to research, I think we have specific questions, ethical questions that come up. Now, as you know, participation in research, the people who participate to do their genetic profiles, they can actually participate in research. We asked our small group of people who were very keen to participate. And as we heard from 23andMe, they have actually a lot of their, people who submitted their profiles, they're keen to participate. Now, the question here that's been raised constantly is whether the person who has their profile in a company as a research participant is protected or not. I mean, it's one thing to have your profile there, and you might have the issues related to privacy, etc. But the question is, if you're a research participant, are mechanisms in place, or are the mechanisms we have in place already adequate to protect the person? You've heard before about the law protecting the research with human subjects. That's a law, but it's been practicing in Switzerland. We've been protecting participants for a long time through ethics review process and other means. In many countries, there are laws, there's international actually guidelines, and all along, the point has been, if somebody is a human, is a research participant, needs to be protected. I'll give you an example. This paper was published last year. Somebody referred to this already in PLOS Genetics. It was web-based, participant-driven studies yield novel genetic associations for common traits, and that was the curly hair and a few other things. I think there was data collected from probably 1,000 participants, if I'm not mistaken that. What was interesting for me is that the paper was accompanied by an editorial entitled Consent and Internet-Enabled Human Genomics. Now, the reason was that the editors of PLOS Genetics recognized, I think that's an interesting quote, the editors recognized that the decision to publish this study without ethics review as human subjects research, and with some concerns over the consent document, and the fact that there's limited access to the raw data will not sit well with some, perhaps many readers. In fact, it didn't sit well with a lot of people, because it created the issue that here we're doing human research that actually doesn't, with human subjects, which doesn't fall in our conventional way and falls through the cracks of our mechanisms. So what they're doing, and I think was a great way to do it, they did put the paper, it took them 6 months to publish the paper, if I am correct. I think, if not 6 months anyway, it took longer than usual. And what they wrote is that we're writing that we've been transparent about our process, but we call for community input to spur efforts to standardize ethics review consent process for genome-wide association research. So the journal itself identified an issue, which is an ethical issue in research, of how to go about it. Now, obviously, we have the mechanisms in place, but it seems that in that mode of research, our mechanisms in place might need to be revisited. Not to be dropped by any means, but they might need to be revisited and to accommodate the new ways we're doing research. Another interesting notion that also is coming up is whether, in the context of research, is whether research participation can be thought of as social responsibility. This is not a new idea. It's been going on for a while. You probably know that it's very hard, if you're doing clinical research, it's really hard to recruit human subjects in the Western countries, and therefore we just go and do our clinical studies in developing countries. There's lots of free riders. We're a lot of free riders. We have the benefits of clinical research. When I got the hospital, I get, the drug that was being tested on so many people, but have I contributed to that research? So we've got lots of free riders in our society. And people have been thinking, should we be thinking of participating in research, in medical research, as something that maybe we all have to tip in a little bit? Now, I give you this photo is quite interesting for me because it comes from, you remember the swine flu epidemic, the Schweinegrippe, and how we all got really worried about that. First, we got worried about the flu, then and we all wanted a vaccine, and then we got worried about the vaccine because we thought it's going to hurt us. So anyway, at this phase where they were doing clinical trials, the question was, who's going to go into the clinical trials to test the vaccine? This is from CNN. These two guys, they're 7 and 10 years old, and they were part of a clinical trial for the first vaccine. The reason I found it interesting is because when they interviewed their parents, because, okay, the kids are young, so they give assent to research. They wouldn't force them, they wouldn't beat them up to do it. But the consent is given by their parents. So the parents said that, well, when they were interviewed, we do that because, first of all, we participate in research. And we think what we want to teach our children is we teach them to protect the environment, to do charity. We also teach them that you always have to put in a little pain for the social good, and that's what you can do with research. It's interesting approach. To me, it gave a photo for that idea. Others have actually gone a step further and been talking about moral duty, not only social responsibility. I think moral duty is a very strong language to use. But what I like in that is, especially in the context of the kind of research we're discussing here, it's a way of thinking about it. Another set of issues is about distributive justice. Equitable access, well, a twofold issue. If those information is out there, people have to pay, you might create a gap. Those who can pay go and get it. Those who cannot pay are not going to get it. So if assuming that this is important, as many people try to say, you create a disparity. Flip side, of that argument. If people are going to the healthcare system, they are getting a lot of things, a lot of unnecessary, perhaps, procedures done. You create an issue of resource allocation. You put your money in the wrong area, and you should be, and you're not, and then you have a problem of equitably distributing the resources, which usually limited that you have. In the research area, again, the issue of equity comes back because we tend to focus on certain populations and we tend to focus on certain diseases. And the question is how much, I think, of those diseases are global diseases or are affecting most of the people. You've heard of the 10 to 9 health research gap. 90% of our health research is actually for only 10% of our population. I was quite happy to see that paper in Nature just last July called Genomes of the World. Well, the authors of that paper argued that we have a sampling bias in genome weight association studies. They argued that only 4% of the studies are done with populations non of European descent. Now, I'll leave it to the expert to discuss whether there's a sampling issue here or not. But what I found really interesting, I was happy to see that on a high-impact journal, is the concern that if we focus very much, as we are now doing that kind of research, maybe we should also be thinking about the underserved people of this world. And this is the majority of the world. So there is a risk of, in fact, creating a bigger equity gap in health disparities that we already have if we keep ignoring these populations. I thought the way they put it, that the most in need must not be the last to receive the benefits of genetic research, is probably something we should be thinking about. And I have to say that's one thing that I guess in these 3 days we didn't hear a lot about. But I think it's something that is have importance. Regarding rights, there's a lot of people discussing the issue about the right to know or the right not to know. We heard about that before, so I won't go into detail. But it's the right to know your genetic information, like the right to know your medical information. People argue that if you know, it enhances your autonomy. Like I said earlier, you know something which is useful, you can act on it. You cannot act on it, but the fact alone that you cannot go and get that information is important. There's clearly the right not to know. Surely, if you want, especially people argue, if there is no treatment or you cannot do anything, a lot of people would prefer not to know. I think it's both of them have to be there. Which right people will choose to exercise, I think it's an individual decision. I also think that there is a component, it's not only a personality issue, it's a cultural issue. Different cultures treat this kind of rights differently. One study recent study, and again, this is just one, interestingly enough showed that the responses regarding desire to know genetic risk for non-preventable disease, as you see, in that particular cohort, people wanted to know. Another issue that brings us more to how the various of those arguments lead us to one or the other direction in relation to regulation is the state's responsibility to protect from harm. The state, in the paternalistic approach, the state has an obligation to protect individuals from harming themselves. And the state is doing this with a bunch of stuff. Now, is this responsibility coming up in the case of direct-to-consumer genetics? And that's what people discuss a lot. I think what's critical in that discussion is to get a clue of what harms are we talking about. And again, to try to assess whether people who are engaging into that kind of activity are able or not to protect themselves alone from these harms. And I'm not sure that we have concluded on that. Again, we have to keep in mind that state protection sometimes clashes with personal liberty. And in some cases, that's OK. In some other cases, it's not OK. But what I think needs to inform these questions is this whole notion of genetic exceptionalism. We are very picky with genetics. We think it's exceptionally interesting, which I think it is, but we also tend to think that when it has to do with genetics, we need to be overly cautious, we have to be maybe overprotective. We're just, very stressed when it comes to that. There's a lot of literature on genetic exceptionalism, and people refute the arguments that genetic information is actually so much more exceptional than a lot of other information that can be used to harm, to benefit, medical information, family history. These are information for which we're cautious, but we just don't get so agitated about. It was interesting, there was a paper reviewing stakeholders in the healthcare sector in the UK and asked them specifically the question of whether they believe genetic exceptionalism is something we should be thinking about. Well, all of them said, and they were coming from insurance, from medicine, from professional association, that no, actually we shouldn't. But they all said in the next question that the public does, and therefore we have to be careful with them. Another twist to that argument, to that point, is people have argued if you create regulation that actually is overprotective or it's highly protective of genetic information, you might be telling people, yes, genetic is much more special than what might actually be. So I don't have a good answer to why society actually has created over time that sort of feeling of exceptionalism, but I also have trouble finding out why why people are creating it. I mean, why is it that if you compare it with other information about an individual, why we get all this sense of exception here? Well, coming to that slide, this is from a paper that was published recently and discussed the issue of where we're going in terms of regulation. If you look at the literature in general, people are going, there are those who argue that, you know, there's nothing wrong with what's going on, just leave it all unregulated, the extreme in one extreme. There are others who think, well, we've got to be very protective of what is out there. There's serious risk, there's serious harms, and let's move to the other end and be very, very restrictive. The paper which I quote because I agree with is that in my feeling of how at least the ethical arguments are being shaping, I cannot see why we could go into either extreme direction. I think the justification, and to me, it doesn't seem adequate. So I would say that if the arguments that have been put forward are telling us anything, they're telling us that we should be moving in some more intermediate position where we have to carefully assess what we've got. We have to carefully look at why we are treating this issue differently than other devices or information. And perhaps we might end up regulating aspects of the process, not the entire thing, which is similar to what we're doing with a bunch of other stuff. So I think in my analysis and how I understand the ethics, because a lot of the regulatory process tells us, well, often it's we argue something, we regulate something on ethical grounds, on cost-effectiveness grounds, but there's always a reference to some ethical principle that need to be respected. And as I said, I feel that the way the arguments have been put forward and analyzed were more or less somewhere here rather than in any of those. So in summary, I think the developments in personal genomics, they definitely, not only they revolutionize or they have the potential to revolutionize the way we do medicine, but I think they do challenge the way we think in ethics, and they certainly challenge a lot of our social norms. Is that a bad thing? No, I don't think it's a bad thing. I think it's actually a great thing. It's a very dynamic thing. It helps us think along. There's clearly a conflict of principles and a conflict of ethical principles in a lot of the things. In some of the principles I presented, you could see the argument going either way, and it might conflict. We don't have a fantastic way of prioritizing principles that conflict. This is what we need to be thinking about. I think that we have to be quite cautious about how we're using ethical arguments in justifying policies or forming attitudes. And I think that what I find actually particularly important is in this dynamic process, we need to be thinking those issues along. The ethical analysis shouldn't be an afterthought. And I think what we've been seeing, though, it's also almost, in this kind of developments, almost impossible to actually leave it for the very end. So that's mine. my ideas about it, and thank you very much for your attention.
Thank you very much, Effy. Open for questions. Thank you.
Thank you very much for the very interesting talk. I have a question. I think you haven't talked about it. Do you think it could be a problem that commercial companies such as 23andMe are offering, a product that people just can get information, and at the same time they offer research? Because I was thinking about personally, actually I would provide my genetic information for research, but I don't want to know my risk profile. And I also have a problem with it that I give it to a company who has other interests than research. What do you think about that?
I mean, it's your choice, really, right? What I think is important in that, you can have your concerns. As you say, you don't want to give your profile there. You would donate your profile to a research center, right, to do research with in a setting. So the good thing is that what's important, I think, is that you are given the option. You're aware of what 23andMe do, or whoever, or any direct-to-consumer genetic company does. And so you decide based on the fact that you don't want them to have your profile for other reasons and only for research, you just don't do it. I mean, I think the important thing here is that you as a consumer have the option and you're very aware of what they're going to do with. And that's where I think our emphasis should be, that you're not misled to believe something else. And is that, the question would always be, how well is that communicated to you or to anybody else who is there? So in fact, if you want to be a research subject because you believe in the importance of that, or that it's social responsibility, I think you'd find another setting to do that. But there are questions, when you said that, you don't, they use it for other purposes. Surely they use it for other purposes. Surely they might use it for purposes they even haven't thought about. We don't know. But there is But I think in entering that sort of agreement with them, what is critically important is you know what you're entering into. And it seems that you do. So you don't like that, then you don't enter.
Thank you. I would like to raise a question about the link between the experts, the research going on, and also the companies and the patients. Because this week, the small chamber of the Swiss Parliament has just decided upon the law on human research, and they decided to not create a special entity who's only concerned about tackling those problems. Do you think it is necessary to create such a institution or something like that, or do you think doctors, medical doctors and researchers are able to provide the link by themselves to make clear to the broad population what the new technologies mean?
Technologies about, inform the public about what kind of technologies are out there, or? Yeah,
and what they in the end mean, because I've got the perception that the population does not necessarily mean what the technologies, what kind of impact the technologies have on their everyday life and on their healthcare.
You're referring to these particular technologies? Well, I think it's, people need to be, I mean, I'm totally for translating information back to the people. I think that's the whole business of that. I think that will be the achievement. In the clinical, in the sort of traditional way of doing clinical research, for example, one of the obligations that seems to come up is that researchers have eventually at the end the obligation to provide to the participants information, findings, what happened. So I guess, and that's the research team. That's how we regulate, well, not regulate, how we do it in the clinical sort of conventional, traditional clinical trial setting. Now, whether in the broader setting that's out of, well, we're talking about this kind of research, somebody has to communicate that to the public, absolutely yes. The question is not always who, the question I guess is how. If you're communicating to the public very in a complex language things, they won't get it. Or, you know, they will get it wrong. The how, I think, to me is more important to pay attention to than to the who. And perhaps, you know, you cannot separate them entirely, but I think that's where I put more my emphasis on that. But I definitely believe it has communicated back, because I don't see how, you know, you can progress into that without it.
If you break it down to in a too simple way, that the risk of the public to getting it wrong is even higher. Because if you just want to explain it in a very, very simple way, the risk that there is a misunderstanding, in my opinion, is also quite high.
But you're talking now about the individual patient or the public in general?
Well, the individual patient, the public consists of the individual patient.
Sure,
so
but it is in a one-to-one session or in...
More one-one relation.
Okay, so in one-to-one session, I guess, you know, this is what, in the clinical context, what doctors do every day. They assess the level of understanding of their patients, and they try to explain to them in a way that they feel, you know, that it's comprehended. So I guess to have a blanket statement on that, it's difficult, because they're, you know, individual capacity, individual level of comprehension. So I'm sure, I guess I would say that model of what we've been doing all along in trying to communicate certain things to the people, we communicate it in a similar way. Now, if your question is whether we have to have somebody there to explaining or not, in case of this test, that's I guess, that's a different question in relation to counseling. But I guess it's an individual thing for most part.
I would like to get back to your argument where you said, well, whether this is a moral issue may be a little bit harsh. And I'm referring to the point that I was really personally struck with when Jamie Haywood mentioned during his talk that in a publicly society-funded healthcare system, it is, in his words, immoral that a personal encounter between a doctor and a patient, evidence is generated, information is generated that may benefit another patient, many other patients, and that this information is kept quiet. It's not that the medical records are being public, but the information should be made public. So he said it was immoral. You say this is a harsh statement. Why?
I say it's a harsh statement. I don't say, what I'm a little concerned about is if we call something a moral duty, we might create an obligation. Well, we create an obligation, we have to be careful about autonomy. So if I tell people here, you all today go and put your medical information or share your medical information, right? Because it's your moral duty, you have the obligation to do that. I'm wondering, I'm a little concerned about how we'll be able to strike the proper balance between respecting people's autonomy, that means what the individual wants to do, right? And how they exercise that self-determination. And so I was more comfortable with the sense of social responsibility. The same way we tell people, do not throw garbage out in the environment. Now we've seen in the beautiful mountains of the Swiss mountains. What we say, I guess, is, and it's a longer process, I think more and more people have understood that, and more people do it. Well, you have the occasional person who just doesn't do it. But I feel that if we're talking about a moral duty, we're pushing for an obligation, which I know you'd like, but, or Jamie would like, but I think we need to be quite careful at finding the right balance in respecting the other principles. That's all. But social responsibility, I like the idea a lot.
Yeah, René.
Thank you very much. The question was raised about information of the public. I think that's a very interesting point. And I wonder, it has not been addressed in your talk, what are the ethical guidelines for media and journalists? Especially in that case, in case of medical reports, but also in other fields. But
in other fields, I was going to say.
Really. But I think here it would be, because it's in a critical way in development, and there are a lot of hopes and risks and whatever it is. And what are there any ethical? You have certainly thought about that.
Well, I have because you know, I've been when I gave interviews to journalists about you know, I told you I worked on controversial issues like assisted reproduction, IVF, and those things. They're very controversial. People get very agitated about it. And when journalists come and ask questions, I'm really also very worried. How are they going to put it? How are they going to put it out? And am I sending the wrong message? And did they say what I said? And all those things. So I think I've thought about it quite a bit. Whether we have guidelines from ethics or from the medical profession, how the media is presenting something, I think we don't per se. But I think and what you observe is correct. Sometimes you read stuff or comes out in the media in the very wrong way. Sometimes it goes in a way that causes anxiety, really, without having any substance. And in a way, it's sort of a self-regulated field. But I think what we're trying to do, for example, I'll just talk about our context, exactly because we believe this kind of information is critically important, and it's at an early stage. We have an initiative. We're trying to do exactly that. We're trying to, the university and the ETHs, trying exactly to get in touch with the media, get the debate out there, and bring the debate out there, not only through the journalists who pick up a piece, publish somewhere, and write about it, but create debate in the public forum. And I think, to a great extent, this is also a little bit our responsibility. This is a very interesting and experimental thing. We're working together from the ethics department with the scientists, and our idea is exactly to do what you're saying, take it out, and we take it out, put it in context. We're not give the answer, but we're going to get people thinking along with us. And that's one example of how we can do it. So hopefully out of that, the media will pitch it right and will give the public the better information. So it's not, again, one size fits all, but I think in the particular case, that's what we will be trying to do.
Before I close this session, the hotel asked me to remind you that the coffee break would be the right moment to check out.
Yes.
Effy, Vayena, thank you very much for this important interview.